everyone. Welcome to today's Endocrinology Grand Rounds. We are very thrilled to have Dr. Yogish Kudva present today on the topic of AID in pregnancy and management of diabetes in pregnancy. Dr. Kudva is currently a professor of medicine in the Department of Endocrinology at the Mayo Clinic in Rochester, Minnesota. He graduated at the top of his class from St. John's Medical College in Bangalore, did his residency in the Postgraduate Institute in Chandigarh, and subsequently, after a brief stint in England, he came to the Mayo Clinic and has been there for the last 30 plus years, moving up from being a resident to a fellow and then faculty and now a professor, and has been an outstanding clinician, educator, and researcher. His focus of research has been in the ways to improve outcomes in patients with diabetes, particularly type 1 diabetes, using advanced technologies and also cell replacement therapy. So his work has been funded by the NIH and other federal agencies, has set up excellent teams for conducting these kinds of trials. And he has over 240 publications and is highly respected for his intellectual abilities. And I must say, once again, I think the last time I was here, I had mentioned it, his mentor there at the Mayo Clinic, Dr. Sri Nair, when he was here, he told me that if you want true scholarship, Kudva is the guy. He really knows things in depth. So it's like the endocrinologist. So we're very happy to have him here, Dr. Kudva.
So that is a very kind introduction, Shri. So I really appreciate that. So I was very fortunate in my medical career, in my medical training, to have teachers like Shri. So I, in my third year of med school, Shri joined as junior faculty, and I was fortunate to have him for 2 years. And he was part of a group of teachers that provided us as role models, examples for humility and for lifelong learning. So I think those are things that stand us in very good stead as we try to move forward. So are you able to hear me when I talk from here? Is this good? Okay. So I've been fortunate to actually consult with some of these industries that I list here. The reimbursement. Okay, great, thank you. So the reimbursement from these industries is paid to a Mayo Clinic Research Fund that supports my time to do that consulting. And then product support from Dexcom, Abbott, and from Insulet, and also Tandem. So our learning objectives today would be to talk about maternal and neonatal morbidity in diabetes, particularly type 1 diabetes, but also type 2. The challenges of optimizing glucose control in type 1 diabetes, which will lead us towards our efforts with AID systems in pregnancy with pre-existing type 1 diabetes. And then we'll talk a bit about managing diabetes in non-type 1 pregnancies. So this slide shows us data from multiple European programs, as is listed here. And so you can see anywhere from 300 plus patients to 5,000 plus patients. And what this shows us is the high morbidity in terms of the mother and in terms of the fetus. The most recent of these publications is from 2017, as you can see, from England and Wales. So in the US, unfortunately, we have limited such data. So the best multi-center effort here is the type 1 diabetes exchange related effort. As you can see, there were only 130 patients in this manuscript reporting various outcomes. And as we can see, there is a significant morbidity with regard to need for C-section, as also the occurrence of gestational hypertension. And then, since these are self-reported, the glucose control is really just a self-reported subjective observation. But I think objectively also providers will vouch for the challenges of adequate glucose control. So to actually continue this sort of reporting, we can see that macrosomia is about 27%, and large for gestational age is about 65%, and neonatal hypoglycemia is 64%. So therefore, pretty significant morbidity. So Helen Murphy had reported in 2017 type 1 data from UK and Wales. And so UK and Wales have the National Diabetes Audit dashboards. And so it is a very large clinical audit and tries to collect data from primary care and from hospitals, so secondary care. And the attempt here is to monitor diabetes care and outcomes and to compare various practices and try to come up with quality improvement and policy development. So these are like interactive dashboards and can provide information about various outcomes of importance and track trends over time so that gaps and variations can be identified, and both clinical studies that are prospective as well as policy modification can be implemented. So the most recent report of this is interesting and alarming. So early onset type 2 diabetes here is reported as less than 40 years of age. And as we can see here, there has been a growth in pregnancies in such individuals in the last decade. Whereas pregnancies with type 1 seems to have changed, seems to have possibly decreased. But the rates of serious adverse pregnancy outcomes are higher in pregnancies complicated by type 2. So we've had a lot of type 1 information that has been published in the first 2 decades of this century, building on information from before. But now that we're encountering more type 2, it appears that we have a formidable problem on our hands. So one of the issues is to look at pregnancy preparation, and that seems to have happened better in type 1 now in the UK, compared to type 2. So the pregnancy preparation has improved. It's still suboptimal, but from close to 13% to 18%. But type 2 diabetes seems to have gone backwards a bit. And then maternal glucose control seems to be improving during pregnancy in type 1, whereas in type 2, though better than type 1, seems to be not consolidating. The good news about CGM in the UK is that most people with type 1 are now using it during pregnancy. So greater than 90% utilization is certainly very good news. So therefore, pregnancy complicated by type 1 is a pretty significant problem, particularly because there are a significant number of people with type 1. And tight glucose control improves adverse health risks. Suboptimal glucose control leads to adverse maternal and fetal health outcomes. And fetal complications are manifold, including fetal loss and birth defects, and preterm delivery, as well as stillbirth and delayed lung maturity. And maternal complications are also formidable. And pregnancy outcomes have improved but are still suboptimal. And so there are multiple challenges here, including changing insulin requirements throughout the pregnancy, not always in a linear manner, and insulin kinetics change, gastric emptying changes, and with all of this, there's increased risk of glycemic emergencies. So these are some of the challenges in this context. So Ohio State had this multidisciplinary program for about 15 years and showed that with close surveillance and close oversight, patients could have improvement in perinatal morbidity and in congenital malformations. So we know that a significant amount of support helps. Of course, this was done at a time when technology was not as well advanced. So in pregnancy, we've now accepted that tighter glucose targets are essential, 63 to 140, and that insulin glucose metabolic changes that are specific to pregnancy are important to address and address in real time with a lot more oversight than previously. But that there are limited data and guidance on fluctuating insulin requirements. So on this slide, you can see daily insulin use during pregnancy, total insulin as well as basal and bolus insulin. Basal and bolus is shown at the bottom here, and daily bolus is shown in dark. And as we can see, the proportion of daily bolus increases as pregnancy progresses, but then you can also see it decreases initially and then increases and then levels off. So therefore, this is something that can be best addressed with some automation. So our aspiration developed around 2019 with a consensus statement is that time in target in the tight target should be greater than 70% and time above 140 should be less than 25%. And then obviously time in hypoglycemic ranges should be no different from the non-pregnant state. So, continuous glucose monitoring and automated insulin delivery have continued to improve, resulting in the AID systems being tested more and more. And in the last 6 years, at least half a dozen updated systems are now available. And these show that AID does work both in children as well as in adults and then also in older people. And that AID clinical use has expanded. But the issue of addressing the needs of pregnant people with pre-existing type 1 diabetes has lagged behind. So that brings us to automated insulin delivery systems and their testing in pregnancy. So the evidence for this has been limited because most clinical trials have excluded people that have been pregnant. Some observational studies as well as randomized trials are emerging. So Helen Murphy and Roman Hovorka from the University of Cambridge in the UK tackled this problem first about 15 years ago now with an inpatient study. And so this, as you can see, the automation here was very early. So there was manual need for system data entry by an RN. And this was a clinical research center study. But they were able to show that overnight time in range could be brought close to 100%. So the same group had follow-up studies. So this is the original study from Diabetes Care in 2011. And as you can see, they enrolled 10 people with a fairly typical profile of early fourth decade and about close to 2 decades of diabetes. And they showed that in early pregnancy and in late pregnancy, glucose control could be optimized with high time in range and appropriate improvement in other CGM metrics. So these subsequent two studies were outpatient studies and were published in the New England Journal and Diabetes Care. And as you can see from the demographics here, similar trial populations, about average age of about 34 years and duration of diabetes of about 2 decades. So they were able to expand the studies beyond the Cambridge Center. So more centers were getting involved. So the initial study was an overnight study. The subsequent study was a day and night study. So the initial overnight study had about 75% time in range, and we would expect a 24-hour study to have more challenges with regard to achieving this time in range, and indeed they did not achieve that time in range. Other important points here is that they did minimize hypoglycemia and they did reduce hyperglycemia, though further reduction would be aspirational. We can see that maternal as well as fetal outcomes in these studies, in these small cohorts, are still significant. So therefore, improving glucose control, but perhaps more than what could be achieved, could improve these numbers further. So around the same time, Helen Murphy wrote this editorial based on two other manuscripts which came out. So these manuscripts are illustrated here. So the Christensen manuscript from Scandinavia and the Dennis Feig manuscript global, including one center only in the US and multiple Canadian and UK centers, showed that every percentage matters in terms of improving glucose control, improving maternal and fetal outcomes, and particularly 5% change in time in range is now proposed and accepted as being associated with better outcomes. So around this time, after quite a bit of effort, a small consortium got funded by the NIH. So the three clinical sites here were Mount Sinai, New York, Sansum Diabetes in Santa Barbara, and we at Mayo Clinic. And we called this the LOESP study in honor of Lois Jovanovic, who was at Sansum and who had long attempted to improve care for pregnant women with pre-existing type 1 diabetes. She herself, as you may know, passed away about age 69 or so. She had had type 1 diabetes for many decades, and she had an obituary in the New York Times. So the LOESP study had phases. Our first phase for the study, and let me also note that it was a long time before we could get this funded, because the funding agency was skeptical about how safe this would be in pregnancy, and wanted enough non-pregnancy studies to be done before this could be approved. So the LOESP study initially started with enrolling individuals with type 1 diabetes on sensor-augmented pump. So at that time in 2018, remember, there was only the Medtronic 670G system that was available, and the hurricane in Puerto Rico affecting their production center resulted in less availability of the device, So essentially, this was an SAP study. And as you can see, most of our patients were Caucasian. For the rest, their data are very similar to the data of the trials that we showed early fourth decade. We enrolled them if they were below 15 weeks gestation. The gestational age at delivery is shown here. So what you can see here is gestational age and the relationship to time in range, and the relationship of time in range of time below range to the gestational age, and also the time above range. And it's important to note that in terms of time in range, when we enrolled 25 patients across 3 centers, the proportion that they achieved 70% or greater was about a quarter of the patients, at any one time, if they were able to achieve greater than 70%. So for the most part, they were in the 60s. And we were also able to now generate data with regard to insulin use and insulin patterns in the course of the pregnancy. So these data informed a closed loop system that could now be developed for pregnancy specific control. So this is a system that was developed for research purpose only. It used an old tandem pump, the tandem AP, and then used the Dexcom that was available at that time. The G4 was available at that time. And so this is the smartphone on which this pregnancy specific zone model predictive control algorithm ran. And so the target range here that we were looking for was 63 to 140, and we had other additional endpoints which are consistent with pregnancy specific guidelines. So the pregnancy specific zone MPC shifted the target zones to lower values and had more assertive meal related strategy and also correction boluses throughout the day, including overnight, and therefore less tolerance for hyperglycemia. And so this is how the interface looked here. As you can see, the effort was to try and make it as patient friendly as possible, provide them with information about their current glucose control, the insulin on board, and also show them their CGM trace. So we published this in 2022. So this involved initial hospital stay. So this was a hospital stay study or a hotel stay study. So we generally have used over the years hotel suites which are across the street from our hospital. So the FDA, in our interaction with them, wanted something like this before the system could be sent home. So you can see that we were able to achieve quite good control here. Now, patients could have user requested bolus, and as you can see, these are very highly motivated women trying to achieve best control for themselves and their fetus. And so you can see an anxious user here who is doing a lot of user requested bolus. And then you can see that, with all of this assertive control, there are certainly risks of hypoglycemia. So this is one of the issues in AID that perhaps we are not capturing as much, and that is predictive hypoglycemia with carbohydrate rescue. I think the hypoglycemia occurrence in non-AID systems is not really as relevant to AID systems. I think in AID systems, we need to capture anticipatory rescue carbs. And I think in pregnancy, that becomes even more important. So the zone MPC algorithm here showed improved control. Here we are showing the demographics, and our patients were using various insulin pumps, had various durations of diabetes. So the green here shows improved glucose control with a narrower band in terms of time in range. And below here, you can see that the time in range is expanding per participant. Each one of these circles is one participant, and that the mean glucose is continually improving. And as we can see here in the table, the time in range is close to 80% or 81%. So about a 17% improvement from the run-in phase, which was about a week. So this allowed us in the early days of the pandemic to move this from in hotel to at home. So the preliminary data that we had generated showing efficacy and safety allowed us to do a home study. The initial NIH funding was only for 4 weeks of home, but the Helmsley Charitable Trust was able to oblige us with a longer duration study. So they provided supplemental funding so that we were able to do this for the rest of the pregnancy. So again, a similar population, so 10 subjects only, average age 33 years, with duration of pump use, which was from 6 months to greater than 10 years. And with the CGM use, again, that was variable. But now we were coming to more or less, you know, much higher CGM use in the population we approached. Again, looking at similar colors here. So the green here would show time in range, the moving average of glucose, the moving average of glucose over a day. And then on the figure on the right here, you can see each participant had an improvement. And when we look at the data, how high was the improvement? It's about a 14% improvement in time in range. And time above range is now reduced by about 10%. But most importantly, the hypoglycemia is also significantly reduced. So those are the data that are available from the US. Now, Europe has a much easier system in terms of oversight for this to progress faster. So the Cambridge group again has come up with this, had come up with this multi-center study, which got slowed down a bit by the pandemic, but they, in a very praiseworthy manner, pushed forward. And you can see 124 subjects randomized to either closed loop or standard care. And the rest of the data here are really similar. Point to note is that at enrollment, the gestational age was about 10 weeks, and at randomization, it was 11 to 12 weeks. So a lot of rigorous information was captured, including the occurrence of complications. So more than half had retinopathy, and previous severe hypoglycemia and DKA by design was generally less than 10%. Surprisingly, alcohol consumption was about 60% going into the pregnancy. The A1C being greater than 7% was shown by about 60 to 80% of patients, depending on the group. Continuous glucose monitoring, naive people here were quite low. Insulin pump use was about 40 to 60%. Total daily insulin use per kg body weight was pretty standard, 0.7. So they were able to improve time in range by about 20%. Now, even standard care will improve, as has been shown in many studies with such oversight, but there is a clear difference of about 10% here. So they had hierarchical testing here, and therefore once statistical significance was lost, then they didn't do any more. So we can look at the data various ways here, including time in target range and improvement in the course of the pregnancy, and clearly closed loop looks better. And time in target range over the course of a day, clearly overnight now is greater than 80%. And the gap between time in target overnight versus daytime remains. Hyperglycemia is just much more difficult to bring into target during the day. So they also provide a reference for the frequency of adverse maternal outcomes and fetal outcomes, as shown in the next few slides. This is one of the issues that has been hampering industry, whether FDA will ask for a change in these outcomes. Because as you can see, these studies were not tailored to these and show these outcomes occurring perhaps, like maternal hypertensive disorder, 20% or less, but the cesarean type is about 50, the cesarean is about 55% or so. So depending on what like this is folded into the study, the numbers of patients may be huge to do, if you want to show a difference in fetal or maternal outcomes. But the glucose control endpoints are much more easy to fulfill with reasonable numbers. So severe hypoglycemia did happen in both cohorts, and the incidence per 100 patient years is about 20. Just for reference, in the non-pregnant population, this incidence with AID is less than 5 and many times closer to 1 per 100 patient years. So that is an important difference. And then looking at other serious adverse events, including device-related events, there are some events certainly in the AID group that need to be addressed. Now, device failure as such is low. So a summary of this is that the CAM-APS system, as it is now called, safely and effectively improves glucose control and could be used in clinical practice, which it is in Europe. The Ipsomed pump, which is a Swiss company, has tried to bring this to the US, but the regulatory framework has not been friendly. So obviously further information about things like this are not easily available to the public. What we know is when the interaction started, and beyond that, knowing that is not easy. Now, the Crystal study used the Medtronic 780G system and used this in Belgium mainly, and was published in the Lancet more than 2 years ago now. Again, enrolled similar type of population with similar, perhaps a little less morbidity. The Cambridge group had 50% retinopathy. Here, there was about 30% retinopathy. And they captured various types of data, including preconception diabetes care, as we've discussed before. And this looks better, as we would expect, than the audit. And the A1C here, greater than 7%, was much less than in the ADAPT study. CGM use now is becoming more or less universal. And insulin pump use in this study was much higher, about 90%. So this was a bit of an atypical study compared to the ADAPT study. Now, time in range here increased by about 6%, but the standard care group also improved, and therefore the effect size here was much less. So this study and the other circuit study using the tandem pump in Canada also show data here, which gives us information about various maternal and fetal outcomes and what the proportions may be. So this would help us with regard to looking at safety for future trials, but also indicates that, doing future trials with these endpoints, we are not going to be able to propose definitive endpoints anytime soon. And again, we have valuable information here about the large for gestational age, which continues to be a challenge. And additional information showed here is that the hypoglycemia risk, both in the mother and in the neonate, is still significant. So hypoglycemia in this population is something that is more than in the non-pregnant population. That is important to factor into future trial design. So the circuit RCT is the most recent RCT in this context and showed an improvement of about 10%. So therefore, not as impressive as some of the other studies, including ADAPT, but better than the Crystal study. Again, this was not a pregnancy-specific system. But the good news is, even though it is not pregnancy-specific, it still shows improvement. So it shows us that the need is high. So they also report other outcomes, including maternal outcomes and the risk of severe hypoglycemia. So the risk of severe hypoglycemia here is low, but still present and not as low as in the non-pregnant population. And the risk of large for gestational age, as shown in the red box, is more than 50%. So AID and future in the US, I think there is still a great need, but enrollment has generally been after 10 weeks. and therefore enrollment before 10 weeks could have even higher impact, and enrollment during the preconception stage would have even higher impact. So therefore, these are important unmet needs. So a study that we have proposed is now approved by the FDA to progress, and uses the twist pump. And the twist system, which uses the tide pool loop algorithm, which was approved by the FDA in 2021, is able to bring target down to 87 and is customizable for pregnancy. As we can see, the target range could be 87 to 180, but the control is at the midpoint. So if we set 87 to 110, it will continually try to bring the patient to 99. So there is a glucose safety range that can be set up that would minimize hypoglycemia, and a pre-meal range for the 1 hour before a meal, which could result in better glucose control postprandial than what we have. And then there's a safe workout range also. So compared to the other pumps that we have, without modification, you can see that the twist pump is in the best position to offer better glucose control in pregnancy. So therefore, we are about to embark on the study working with 3 other sites. So it will be a 4-center study, and it will initially have a phase 2, which would be lesser number of subjects, and then a phase 3, which would add to the subjects. So that is something we have discussed with the FDA, and that process and the implementation is continuing. So in the last few minutes, we look at managing diabetes in non-type 1 pregnancies, including pre-existing type 2, glucokinase example of monogenic diabetes. And obviously, we have to face the fact that there are more patients now with bariatric surgery with and without pre-existing diabetes who will get pregnant. So 2 studies, the MIGHTY RCT looked at metformin along with insulin, and patients were randomized to metformin or placebo. This was a good sample size of about 500 subjects equally randomized. The metformin use resulted in lesser maternal weight gain and somewhat reduced insulin requirements. But there was a higher rate of small for gestational age infants in the metformin group. Overall, the primary composite neonatal outcome established by the hyperglycemia and pregnancy outcome study, the HAPO study, was no different between the groups. And then the MOMPOD RCT also looked at metformin versus placebo, and this was again added to insulin. So this was published in the JAMA now about 3 years ago, and had about 800 subjects now, and looked at various neonatal outcomes as well as large for gestational age outcomes. So this did not reduce the composite neonatal adverse outcome, and the reduction in odds of LGA, the effect of the reduction in odds needs to be further evaluated. So additional endpoints here are shown, including cesarean section, and then the birth weight. You can see mean birth weight was a bit less compared to the insulin plus placebo. But again, SGA and LGA in the 2 studies were somewhat different. So the glucokinase MODY mutation, is much more frequent, and particularly in the course of pregnancy may actually be diagnosed for the first time. So a BMI of less than 25 with a fasting glucose greater than 5.5 can help identify these women. And then both glucose levels and fetal genetic variants influence birth weight, and knowing the fetal genotype does help with precision management of maternal hyperglycemia. So doing non-invasive prenatal testing to identify this could lead to one of 2 pathways. If the fetus inherits the mutation, then no treatment is usually required. If the fetus does not inherit the mutation, there is a risk of macrosomia. So the maternal hyperglycemia needs to be treated. So in bariatric surgery, the field is just starting out in terms of looking at these data. And so the largest study to date that I know of included 130 pre-existing diabetes patients. It did not report a reduction in impaired glucose tolerance after bariatric surgery here. And it reflects improved insulin sensitivity and metabolic control in women who had type 2 diabetes prior to pregnancy. So it does seem to help, but the data are retrospective. So we return to the National Diabetes Audit. So one of their mandates is to improve glucose control and outcomes in type 2 diabetes. So their thoughtful approach to this is to do something that was done in the concept study, which showed that CGM in type 1 makes a difference. So here they are trying to look at CGM in type 2, and we'll look at how much of a difference does that. So recruitment is ongoing at this time, and they are hoping to complete the study next year. So hopefully there will be data in 2028. And the Helmsley Charitable Trust has funded the study to look at type 1 diabetes pregnancy, just capturing information about what are patients doing, how is their glucose control, what are their outcomes. So this is being overseen by the Jabe Center in Tampa, Florida, and 3 centers, Barbara Davis and Mount Sinai and Pennsylvania, are serving as the coordinating centers. And hopefully we'll have more information next year. The Beta Bionic program at Mass General has been funded to do studies initially in non-pregnant individuals of the Beta Bionic system, and to bring these studies to clinical, to the pregnant context subsequently. So therefore, you can see the type 2 studies of CGM will likely get released in 2028. And then the Beta Bionic studies will likely give us more information, perhaps by 2030. And we are hoping to do the TWIST study in type 1 pregnancy and get that to a pivotal stage with results, hopefully in late 2028 or early 2029. So the next 2 to 4 years are a lot of work for many of us investigators. So Tiger is the character here with the baseball cap and his brother Pumpkinhead. So this is a very interesting cartoon from Bud Blake in Maine, who lived at the same time as Charlie Brown from Minnesota. And the dog, I don't know why with spots he's called Stripe. But, I view myself as Pumpkinhead trying to teach. But, I think we have very effective educators. And so those are the CDEs and our clinical trial educators who do a much better job than I do. So therefore, the results that we present is the consequence of various multidisciplinary teams and investigators at multiple sites. So I'm grateful to be talking to you. And thank you. Mm. Yeah. So the first studies were the Cambridge studies. So the initial Cambridge study was just using one algorithm, their same algorithm. So that was 2011. The subsequent studies, the 2016 and 18 studies, used improved algorithms, but not pregnancy specific. But the ADAPT study, which was in the New England Journal, used a boost feature, which they have, which enables them to tighten control. And so that is similar to the system that our study used, which was developed by the Harvard group, by the Santa Barbara moved to Harvard, Frank Doyle, Eyal Dasu group. And that was more assertive control. So these studies used more pregnancy specific. So the current TWIST study that we are proposing is not pregnancy specific, but the system has enough customization that it allows us to approach approach the patient with pregnancy-specific goals. So I think that is good enough for now, but we'll have to see how good it is. Yes, yeah. No, there is not. There is not. So the hope of the investigators is that these studies will show us if the system is getting stressed. So usually there is an increase in insulin sensitivity as the first trimester comes to an end. And that is important, and that probably reflects organogenesis. And the second trimester onwards, there is now an increase in insulin resistance. And then that plateaus off. It doesn't increase anymore as the pregnancy comes to an end. So we'll see whether beyond having a closed loop system that responds to changing glucose, whether more changes are needed. We are not planning for that at the moment. Yeah. So the circuit study, that's the tandem, as well as the Medtronic 780G did not change anything. In fact, a big controversy with the 780G system was about how patients used fake carbs to push the system in pregnancy. And that is something in our study that we are actively being mandated to ask patients not to do, and then to capture that information on an ongoing basis. So our optimization of glucose control is going to be week to week from 4 to 10 weeks. Inclusion eligibility in the study is 4 to 10 weeks of gestation. And then we will have video visits every 4 weeks, a virtual visit of some kind, data review and either phone-directed optimization or medical record-related communication of the optimization every week, and then in-person visit at 20 and 32 weeks. So hopefully that will give us valuable information about how much can we achieve here and how much more is needed. I think one of the nervousness in the field is that one of the issues of nervousness is that maternal and fetal outcomes, there are still concerns. And how would that look, but those studies are very huge. I think doing them with the level of infrastructure now, the level of experience we have now, as well as the funding available, is very forbidding. Yeah. I think Dr. Lee is here, right? Dr. Lee, yeah. So he and I had a long conversation today morning. So I think it's been interesting watching this evolution, So Medtronic was the industry leader for many years. And as JDRF and Helmsley and NIH and foundation and other smaller private foundations came forward, I think it pushed more money towards the smaller industries that were available at that time. But now in the last 7 years, there has been a tremendous sort of expansion of this, so much so that the market is dominated by certain industries, and then startups are going to find it very challenging, And now the priority has changed so much towards trying to expand this to as many people as possible without any sort of complicated clinical context. Pregnancy is a complicated clinical context in terms of getting things approved, So we tried to do this work from 2014 onwards, and Carol Levy from 2012 onwards. And this is how far we have come. I think the landscape for pregnancy studies in this context continues to be very challenging. I think we have to get one pivotal study in the US done and hopefully approved before we can see more. I think right now the priority of various systems that have got good market share is to do less automation and expand it to more automation, less user engagement, and expand it to more people. Yeah. Yes. Yeah, that's a great question. So the question is about the TWIST study. So we've not yet started recruitment. We are hoping to start in June. And the reason is that initially when we started the study, this started as more of an investigator-initiated effort. So now we are trying to get the database much more FDA compatible, so that the phase 2 and the phase 3 can sort of be combined. And this is working with the FDA. We're trying to do this in a way that makes that happen. So we would love to start that as early as possible. So even today, I requested access because we had work to do related to that, So between meetings, etc., I've been trying to do work for that to get it forward. So yeah, June, hopefully. And so we've not published this on a clinical trial website yet, but we expect to register it within the next month. So thank you for your interest. So at the moment, we have 4 sites. In the Midwest, it's just Rochester. And then we have Mount Sinai. We have Barbara Davis in Denver. Then we have Stanford in the Bay Area. Yes. Yeah. Oh, it is higher. There is no doubt. It is higher. And I think it's partly related to the motivations of these mothers. I think this is one of the continuing challenges, right? In throughout this field, as we've tried to work with the FDA in this field, I think both as providers, as engineers, and as FDA regulators, one of the limiting factors being asked of control systems is to limit hypoglycemia. Any recommendation which increases hypoglycemia is dampened in the control system. And yet, particularly during pregnancy for women, their motivation is to avoid hyperglycemia. So the user interface and how much they can do really matters to them, Yeah, it is, I think, but how much they do is amazing, right? I think during pregnancy, how much they do, how much initiative they take, how much day and night they are up. I think we have been trying to address it as best as we can, but so when we did these studies, we did the hotel study, and then we did the outpatient throughout the pregnancy study with week-to-week follow-up and sometimes every 3-day follow-up. So the data safety monitoring board that we set up with FDA instruction, we were supposed to look at CGM data, optimize CGM week to week, and report to the DSMB about 2 weekly control, you see. So we had to enroll first 1 patient and take them through 4 weeks, and then enroll 2 more and take 3 through 4 weeks before we could enroll more. And every site was there was a cap on how many could be enrolled at any one site at one time, So that has gotten better. I think the FDA is impressed by how we did with that study. But still, it's been slow getting this going. Yeah, yeah. So the numbers are small, Shri, for us to draw too many conclusions there. I think the Danish study, which came out recently last year in Diabetes Care in 2025, is interesting because that shows that in the large cohort of type 1 that became pregnant, baseline retinopathy is much lower than previously reported. And the number of people that have significant retinopathy is quite small, and worsening of retinopathy is restricted to them. And what they weren't able to address is how stable is if the advanced retinopathy is stable, does that still progress? Those numbers are small, but those data are, reassuring. Yeah, so the European audit might give us more insight into that. But the audit that we would have to see to get more insight would be the next audit. You know, I don't know whether that would start in 2025 because they have a 3-year audit that ended in 2024. So that might give us some insight. And then the Cambridge system is now available in Germany and in Switzerland and in the Netherlands, and so therefore Austria. So it would give us those would give us more information. The in the US there is the T1D pregnancy and me, the PRAM T1D study, funded by Helmsley, and that would give us information about AID and non-AID control and also outcomes. So that is an N of 500 study, so that is the closest we will come in the US. So the N of 500 study is likely to be reported at the ADA in 2028. So I think that's the next milestone we have to reach here. Yeah. Uh, sure. Else? Yeah. Well, it's possible, I think, Dr. Lee, that we will see people who are separated into different groups. I think one of the challenges with pregnancy studies is getting access to systems. You know, I think we just have to go with the system that is available. Um, Developing an insulin pump is formidably challenging now, and getting it through regulatory, etc. So we will see how this works out. I think the good news is that now the AID field has matured enough that we can look at various types of exploratory outcomes. So, exploratory outcomes could include looking at CGM metrics in composite for example, all 5 CGM metrics, what is the proportion that have achieved it? And then dividing them into two, those that achieved all 5 or those that didn't achieve all 5. A second would be trying to define greater than 70% time range, how many reached it at any one point in pregnancy versus not, So we looked at that in the sensor augmented pump study of lowest P, and we showed that only 5 out of 25 reached 70% at any one point in pregnancy. And then we looked at that in the lowest P study lasting throughout pregnancy, now with AID, and we showed that 8 out of 10 people reached 70% at any one point in pregnancy, and those that reached it did it for longer, So that is convincing enough. You're going from 20% to 80%. And that is the closest I know, because these are data that we generated and we looked at, The other cohorts don't always report data like this, but I think those are reasonable data to look at as we go forward. And you could apply that logic also to non-pregnant AID use. Yeah. Certainly they would help. I think we've been collecting data with regard to physical activity, for example. But the challenges there are going to be that, what kind of device do you use? The physical activity trackers are all consumer grade. They are not medical grade, So can you use consumer grade devices? And also, these consumer grade systems have to be recharged. And what is the challenge of having them charged at all times? And are real-time data available that are actionable? All these three are formidable challenges, So we've tried to use various activity trackers. They are consumer grade, but then they require recharging, and getting actionable information in real time is very challenging. So this, unfortunately, has been a problem that has plagued the field for 20 years. In CGM, for example, I started using CGM when it was non-real time, so that was 1995. 1999. So for it to go from non-real time to non-adjunctive use, which was good for AID systems, took 16 years. It shouldn't have, but it did. So now we will see, how this field can go forward with other wearables. I think it's a good question, but I'm still seeing some structural systemic issues, which I hope can be addressed. Insulin pens. Yeah, certainly smart insulin pens could be incorporated better. And then there is a very interesting use of insulin pen with additional technology by a company from Luna, which is worth looking at. Yes, please. Right. Yeah. Yeah, it's a great question. So the question is about gestational diabetes and such type of control in gestational diabetes. So I didn't say anything about gestational diabetes because that's a huge field. Also, it's a field, it's very dynamic. And so there are more investigators working in that field, including my collaborators, Carol Levy and Sarit Polsky. And so they are doing work with both trying to define gestational diabetes better. So there's a large Helmsley Foundation study called Imagine, which is going to start soon. And then there's also an inhaled insulin use study that is ongoing. And I think, if we look at AID in the context of type 2, and we'll talk about it tomorrow. Honestly, when you decide that you need complex insulin therapy in a type 2, there is no reason not to go to an AID right away, you know. So that is the mindset I think we probably need to bring towards gestational also. But one of the things one has to do is define what are meaningful endpoints here.